Now we're on page 44, and this is exercise number 6. Once again, we'll start on the left side of the page, and we'll look at the inferior leads here that reflect the RCA, and there's no ST elevation in 2, no ST elevation in 3, if anything, maybe a little bit of ST sagging. No ST elevation in AVF, so we rule out inferior wall MI. Now we'll look at the anteroseptal leads, which are fed by the LAD, the left anterior descending coronary artery. And we definitely see ST elevation of V1. We see ST elevation, here's a J point of V2. We see ST elevation in V3, here's the J point way up there. We see ST elevation in V4. So we definitely have an anteroseptal wall MI. If we carry on, look at V5, we have ST elevation here. I think that's a J point roughly there. It's hard to say for sure. V6, we have ST elevation as well. So we know we have lateral wall infarct. Now let's look at the other lateral leads, 1 and AVL. Looks like about 2 millimeters in 1 and maybe 1 or 2 millimeters in AVL. So we have the septum, the anterior portion, and the lateral portion involved. We simply call this an anterolateral wall MI, not an anteroseptal lateral wall MI, but an anterolateral wall MI. And again, as with the other example of the anterolateral wall MI, this will be a patient who's occluded their left main coronary artery. That's a very high occlusion. That means this patient will have a very extensive myocardial infarction. These are the patients who are at a very high risk of going into cardiogenic shock, where they've, lost more than 40% of their myocardium. And so if you see this kind of ECG change and the patient's not already hemodynamically unstable and in pulmonary edema, chances are very good they're heading down that path. So this is not a patient you want to mess around with. You want to keep your scene time to a bare minimum.